Okay, we want to have a live conversation right now with Dr. Jacobson. We've talked with him before. He's the Professor Emeritus of Medical Ethics and Infectious Diseases at University of Utah Health. And Dr. Jacobson, we really appreciate you spending some time and giving us a sense or at least some more understanding of what's happening. The first thing I want to begin with is really where we are right now. We hear the concerns about hospital capacity. How concerned should we be about that, about ventilators, those sorts of things?
Well, I think the concern is very genuine. We haven't yet in our community overwhelmed the available resources. But I think based on experience in other countries, certainly Italy and what we're beginning to see in New York City, I think the idea of taxing those resources is really of major concern. And fortunately, our hospitals are beginning to prepare.
And when you say taxing those resources, what that eventually means, if they get overtaxed, is deciding who gets the resources, right? I mean, these are you're a medical ethicist. These are really difficult decisions that could be coming the way of our hospitals, our doctors.
Well, they really are very difficult decisions, and we're very fortunate. We know that sometimes even the best laid plans don't work out, but everyone agrees that planning is very important. And Utah, through the Utah Hospital Association and the Utah Department of Health, have been working for years on what are called crisis standards of care to help make decisions that are the difficult ones you mentioned in situations exactly like this. I think we learned what the wrong way is, or the least appropriate. The wrong way would be to be arbitrary or to exercise personal preferences or to be idiosyncratic by the choices that some physicians would make. A better way is that planning process which anticipates what could happen when our resources are very limited and how we could make the best use of those resources, primarily to emphasize people who would be the most likely to benefit from them.
So what that would ultimately mean is prioritizing care, right, and having some guidelines that you absolutely follow, which would be if you're this age or this level of health or that sort of thing, then you're more likely to get treatment than somebody who's not, if we were to get to that point.
I think that's exactly right. And it's important that those guidelines be developed with the input of skilled professionals and the public. And even more important, that they be well communicated to the doctors on the front line and the administrators who are often responsible for helping to make decisions about scarce resources. As to the point that you made, not only should these be in place up front, even before people are sent to the hospital or admitted to the hospital or admitted to the ICU, but they need to keep being followed because we know that things change over time. And people who might have been very promising in terms of their outcome early on with interventions may continue to get worse. And that may be a difficult situation where the scarce resource is better used for someone else.
Okay, we are completely out of time, Dr. Jacobson. I did want to end it. If you can give us like a sentence or two, just saying, do you see any hope? Are we doing the right things?
I think we are, and I think the public can help. The worst tragedy I can imagine is someone who does not wish to be in the ICU on a ventilator, who's emergently brought to the hospital and is taking the use of that resource and making it unavailable for someone else. This is a great time for the public to be thinking about what their preferences are and communicating those really clearly.
To your loved ones and living wills, that sort of thing. Hey, Dr. Jacobson, really appreciate your time. I'm sure we're going to lean on your expertise more in the future. Thank you for this.
Thanks very much.